This conference will now be recorded.
Hello, everybody, and Dr. Schweitzer. Pretty familiar with with some of your work, and we've been following you for a long time. I am much involved with our advanced group, and so from that standpoint, very interested in what's going on up at Hutch and Seattle Cancer Care. But I actually just wanted to relate very quickly to everybody. One of the findings that was in the survey that we did a couple of weeks ago that we've submitted as an abstract to the AUA about the importance of virtual support groups. And the reason I want to raise this is because I had this very experience myself today, and it was really a great experience. We found that 2/3 of people who attend our groups, all our groups, doesn't matter what level of prostate cancer, make contact outside of the group with somebody or the other. And of that, I think something like 50% indicated that they made friends with those people. It might have even been 2/3. I don't know. I'd have to go back and look. But that was really heartwarming to me. And the reason I raise it is because I met a guy that we've been supporting for a couple of years for lunch today with his wife because I just found out they happen to have a house local to where I live, and they were visiting from Connecticut. And it was a great experience. I also learned, we didn't know this before, that he's a VA psychiatrist specializing in addiction issues and drug alcohol addiction issues. And it was just a pleasure. So I just hope that if you haven't reached out to other people in this group, that you will. And my guess is that you'll find all of them very receptive to talking to you, to supporting you, and maybe you even make a few lifelong friends, as I have. And with that, I'll turn it back to Joe and to Dr. Schweitzer.
Okay, thanks, Rick. Okay, so to get the program kicked off, I'm going to turn it over to Howard. Howard will be moderating for the evening, and he and Hugh, as I said, will be managing the Q&A after Dr. Schweizer's presentation. So with that, over to you, Howard.
Okay, thanks, Joe. So Dr. Michael Schweitzer is an assistant professor at the Department of Medicine in the Division of Medical Oncology at the University of Washington School of Medicine. He is also a physician at the Seattle Cancer Care Alliance. His research involves translational genitourinary cancer, and his goal is to help reduce morbidity and mortality associated with diseases like prostate cancer through developing novel drug therapies. And that's what he's here to talk to us about tonight. He's going to be talking about medication that's shown some benefit for men with advanced prostate cancer. And he is now studying whether the same medicine could be beneficial for men on active surveillance. And with that, I'll turn it over to Dr. Schweitzer.
All right. Yeah, thanks so much for the invitation. It's really great to be here. So I'm a medical oncologist by training, which does exactly what it sounds like. I use medicines to treat cancers. And so, historically, we haven't had a huge role in active surveillance, but I got interested in the idea that, we've got a lot of, really potent prostate cancer therapies that work for men with really advanced, hard to treat cancers. And it sort of just made logical sense to me that we should try to use some of those drugs and that experience from treating sort of really end stage cancers and see if maybe we can use some of those lessons to affect change for guys with earlier stages of their cancer, particularly in this case, men on active surveillance. So I'll talk to you a little bit about some of that work that we've been doing at our center. So here's an outline for the talk. I'm going to first go into a little bit of prostate cancer biology, since I think this is really important in terms of trying to understand, why we use drugs that we do. Talk a little bit about prostate cancer background, and then go into a little bit about sort of the local management of prostate cancer, which I think is important to sort of keep in context for why we need active surveillance in the first place. And then at the end, I'll talk a little bit about some of the studies that are being done looking at using medical therapies to treat men who are on active surveillance. So I think one of the most fundamental things that we need to appreciate about prostate cancer is that almost all prostate cancers are addicted to testosterone and other male sex hormones. The other name for that are androgens collectively. And so the way that prostate cancers utilize androgens or testosterone to fuel their growth is sort of outlined in this cartoon. So essentially what happens is you've got a prostate cancer cell that's, either in the prostate itself or maybe it's spread somewhere else, but it's fed by blood, just like any other cell in your body. And within the blood, there's circulating androgens like testosterone and dihydrotestosterone. These androgens, when they encounter a cancer cell or even normal prostate cells for that matter, they migrate into the cell itself. And once they get inside of the cell's cytoplasm, the part outside where the DNA lives, it binds with something called the androgen receptor. And then this complex, the androgen bound to the androgen receptor, then migrates into the nucleus of the cell where it hooks up with the DNA of that cell. And at this point, the complex there triggers that DNA to start reading it and producing proteins, which tell the cancer cell to grow and proliferate and spread and do bad things. It also tells it to make proteins that we can measure, such as PSA. And so PSA is a direct readout of this process happening, which is part of the reason we look at it when we're trying to decide, who we might want to do a prostate biopsy on, or even when we're trying to assess whether or not our drugs are working. When we think about treating prostate cancers with medical therapies, the backbone for treatment really involves trying to prevent this process from happening, preventing that androgen receptor from triggering that cancer cell to do bad things. And so we do that in a number of ways. The sort of traditional way, the one that we've been around for decades now, is using androgen deprivation therapies like Lupron, where you essentially decrease the amount of androgens that are in circulation in the bloodstream. Basically, drugs like Lupron tell the testicles to not make testosterone, which is the primary place where testosterone is generated in a guy. Other approaches involve trying to lower circulating androgens even more with drugs like abiraterone. The brand name is Zytiga. This essentially cuts off androgen supplies from other places like the adrenal gland. And then newer drugs like enzalutamide, apalutamide, darolutamide all work essentially the same way. They all work by blocking testosterone and other androgens from binding with that receptor. But again, the mainstay of what we're trying to accomplish here is really just preventing androgens from binding the receptor and triggering this cancer cell to do what we don't want it to do. And so we've got a lot of really effective tools to make that happen. When we think about sort of prostate cancer as a disease continuum, you can model it sort of similar to what's pictured on this graph here. And so if you imagine a patient who presents initially with cancer that's just in the prostate, they tend to have a relatively low tumor volume. Many times they'll present after it's grown to a point where you actually appreciate that it's there in the first place. And these guys are typically treated with local therapies like prostatectomy surgery, radiation therapy, things like that. Many of these patients are going to be cured. In fact, most of them probably are cured after getting radiation or surgery. But some men will either progress after local therapy or they present with more advanced cancers. And it's at this stage that we really think about using androgen deprivation therapy as sort of our backbone of treatment. We call this phase of the cancer hormone-sensitive prostate cancer because the cancer is susceptible to these hormonal manipulations that we use. And 90% or more of men are going to respond to this with their cancer shrinking in size, the PSA dropping, and this effect can last for several years in most cases. Eventually, though, most men with advanced cancers who are on these initial sort of androgen deprivation therapies are going to progress. At this point, we say that they develop castrate-resistant prostate cancer. That's the medical term for somebody that's progressed in spite of being on drugs like androgen deprivation therapy with Lupron. Since 2012 or so, there's been a lot of new drugs that have been approved. Primarily, they're initially studied in guys with this late stage of prostate cancer, this castrate-resistant prostate cancer. And I've listed the drugs that are currently approved there on the bottom right. All these agents were initially approved again at sort of this late stage, but over the past few years, a number of studies have shown that when you shift the use of these drugs earlier on to men who have advanced cancer and the metastatic present with metastatic disease, and you use these drugs early on, you really see a much more pronounced effect in terms of how long these drugs work to control the cancer, and it also translates to men living significantly longer. So we've got a lot of tools in our toolkit now that are effective at treating prostate cancers. And what I've been interested in is seeing whether or not we can take some of these drugs and shift them even further down the treatment paradigm and try to use them in men that either have, say, high risk cancer who need to get surgery or radiation, or even guys who are on active surveillance and are maybe looking at alternative strategies that would allow them to hopefully stay on active surveillance and avoid having to go get surgery or radiation to treat their cancers. All right, so just shifting gears, talk a little bit about prostate cancer background. So I'm sure a lot of you guys have probably heard these statistics already, but I'll just run through it quickly in case people aren't familiar with it. But prostate cancer is a big problem. Right now, it is the most common cancer affecting men in the United States, aside from sort of local little skin cancers. About 248,000 men are expected to be diagnosed with prostate cancer in the US in 2021. And overall, a little over 34,000 guys are going to die of prostate cancer this year. And so it's a major health issue. I think one of the big things that is challenging about treating this cancer is that you'll note that it's almost an order of magnitude more men are diagnosed with prostate cancer compared to those that actually succumb to the disease. And so trying to understand, who are those subset of patients that really need to get treated, that are at risk of having a life-threatening cancer, has been one of the major challenges in terms of how we approach managing it. This is just looking at the epidemiology of prostate cancer. It's the brown line on the graph to the right. And this is looking at the incidence of prostate cancer over time from 1975 until present out of 100,000 population. And you can see that prostate cancer incidence really had a sharp upward turn somewhere around 1992. And this corresponds to when PSA screening really became widespread. You can imagine that once you have a test that allows you to identify more men with a certain type of cancer, you're going to see that incidence shoots up dramatically. And they saw just that. It did plateau for a number of years, and then you see that it takes another sharp downturn a little after 2010, which corresponds to when the United States Preventive Service Task Force came out with some recommendation that was probably not well informed, but essentially recommended that men not get PSA screening anymore. And so a lot of primary care doctors shifted away from doing PSA testing or screening for prostate cancer in the first place. They've actually reversed gears come 2018 and are now recommending that we consider PSA testing again. And so you can see that there's a little bit of an upturn in terms of diagnosis of prostate cancer. As far as the sort of workup for a patient you might suspect had prostate cancer, this typically is prompted by either an abnormal digital rectal exam, you feel a nodule in the prostate, for instance, or you're probably more commonly you find somebody that has an elevated PSA. Typically at that point, patients are referred to a urologist who would do a biopsy, and depending on sort of the risk factors of that individual based on PSA, whether there's a nodule that's palpable on the prostate, and probably most importantly, the Gleason score, they sort of put you in these different risk groups. And I've listed them in a table form on the right. There's little variations on it, but this is sort of essentially the way most people sort of look at prostate cancer when it's still localized, confined to the prostate itself. The most important prognostic factor in guys with localized prostate cancer is still the Gleason score. And so the Gleason score is essentially just a way to describe how the prostate looks under a microscope. They range it from 1 being sort of the most low risk, the most normal appearing prostate cancer, to 5, where it's very high risk and very abnormal appearing. And when we say abnormal, that means that when you look at the cancer itself, it looks really different compared to normal, healthy prostate tissue. And again, this correlates really closely with the clinical behavior of that cancer. Typically, it's reported as a composite score. So for instance, I'll report the primary and secondary Gleason patterns. So what they do is they look at the biopsy specimen under a microscope, and they'll say, okay, this looks like it's mostly Gleason pattern 3, but there's a little bit of Gleason pattern 4 there. And so they'll report it out as Gleason pattern 3 plus 4 equals 7. And that's sort of how we usually think about sort of the Gleason score when we're trying to sort of decide how high risk an individual is and how, important it is for them to treat their cancer versus whether they might, for instance, be a candidate for something like active surveillance. The World Health Organization and the International Society of Urologic Pathology have put out this sort of revised framework for looking at Gleason scores. They call the Gleason grade group system. It essentially tries to sort of refine the way we lump these together. Instead of just saying Gleason 6, 7, 8, 9, they put them into these grade groups where they differentiate between, say, Gleason pattern 3+4 versus 4+3. And so they do that because they actually see different clinical outcomes. If you've got a biopsy that shows mostly Gleason 3 and a little 4, they tend to behave less aggressively than somebody that's got mostly Gleason pattern 4 with a little bit of 3. So it's a little confusing, and this is a bit of a nuanced issue here, but it does make a difference in terms of trying to provide prognostic information. And this is just one example of a large study where they looked at outcomes of patients who either underwent prostatectomy on the top, surgery for their prostate cancer, or radiation on the bottom. And what they did was they basically just color-coded the Gleason grade group from 1 through 5, and you can see that this stratifies the outcomes pretty well. So on this figure, essentially it's showing the chances that you'll remain recurrence-free, so that your cancer will not come back. And you can see that for the grade group 1, for instance, the green line, that whether you get surgery or radiation, they tend to have a really low rate that the cancer comes back, whereas for the purple line, the grade group 5, you see that there's a much higher probability that the cancer recurs. And so this sort of just highlights that Gleason score, Gleason grade group is really the most important factor when we're trying to understand the risk that the cancer might cause problems down the line. All right, so now I want to talk a little bit about local management. Again, I think that this is important because it puts into context for why we might think about doing active surveillance in the first place. So as far as local treatment, there's essentially two sort of main flavors, either radical prostatectomy, surgical removal of the prostate, or radiation therapy. And radiation therapy can include traditional external beam therapy, which can be sort of standard photon-based therapy versus things like proton therapy. It's all basically just shooting radiation at the prostate itself from an external source. Brachytherapy is when you implant radioactive seeds, and then sometimes they do a combination of the two. And then, of course, another mode of local management is active surveillance. And we'll get into this in more detail, but as most of you probably know, this is typically for guys that have usually low to intermediate risk cancer or even more favorable risk cancers. Usually this is something that we would avoid for guys that have sort of traditional intermediate risk to high risk disease. So there's been 3 big randomized controlled trials that were specifically looking at whether or not treating somebody's prostate cancer with surgery and or radiation therapy was beneficial. And typically when we think about sort of the gold standard for deciding what type of cancer therapy should become our standard of care, we usually like to show that a certain therapy is going to result in men living longer and not dying from their cancer, since that's, you know, probably the most important thing for most men, especially when you're dealing with a more aggressive type of cancer. And so all of these studies were really geared at looking at survival following either surgery or radiation therapy. The first study, and the one that has the longest follow-up of all of them, is the Spcg4 study. And this was a study that was looking at either radical prostatectomy or observation alone. As far as the demographics of who enrolled, these were guys that had either T1 or T2 prostate cancer. And that means that you either couldn't feel a prostate nodule at all, which is T1, or if you felt it, it was just in one location. Overall, they enrolled 695 patients. On average, their PSA was around 13. 12% had prostate tumors that they couldn't actually feel on a digital rectal. 64% of the patients had intermediate or high risk cancer. And it was really long follow-up, almost 24 years. And what they showed essentially was that in patients that got treated with surgery, that they had decreased rates of death. They lived longer compared to patients who just went to observation alone. It was 72% of patients on the surgery arm died versus 84%. And those numbers sound high, but remember, this follow-up for this study was quite long at 24 years. And if the average age of somebody with prostate cancer is 65 to 70 years old, that's putting most of these men well into their 90s. So it's something that's unfortunately an unavoidable part of life, that everybody dies eventually. But overall, I did see differences here in terms of improved survival when patients got a surgery versus not. This translated to an overall mean years of life gained in the surgery group of about 3 years. They also showed that surgery was associated with decreased rates of metastatic disease, 27 versus 43%, and that overall these benefits were most pronounced in men who were under 65 years of age and also those who had intermediate risk cancer. The next study is the PIVOT trial, and this was also a relatively large study, similar patient population. They enrolled 731 men. The average PSA was 7.8. There was a higher rate of patients with non-palpable prostate tumors, 50% here, but similar rates of intermediate high-risk cancers, 66%. The follow-up was only 10 years though, so a lot shorter. Overall, they actually didn't see any clear difference in survival between patients who got prostatectomy versus just observation alone. 47% of men in the prostatectomy arm died versus about 50% in the observation arm. So maybe a little better, but it wasn't enough to say that it was clearly different based on some of the statistics that they did. They did, however, note that patients that had higher risk factors, so had a PSA over 10 or who had intermediate or high risk cancers, looked like they tended to do better with surgery. They also showed, again, not surprisingly, that patients that got their prostate cancer treated with surgery had lower rates of developing metastatic disease, 4.7 versus 10.6%. The last study was looking at surgery, radiation, or just observation. It was the PROTECT study. Again, similar patient population. This was a really big study, mainly because they had 3 arms this time instead of 2. Enrolled us over 1,600 men. PSA on average was pretty low, 4.6. And Gleason 6 cancer, which is, again, low risk, 77% of patients. So relatively low risk population compared to some of the other 2. Again, they showed that overall there was no difference in survival between groups. And in fact, after 10 years of follow-up, there was really just a handful of patients who did pass away out of these 1,600 patients. So they weren't able to detect whether there was really a difference associated with getting your prostate treated. They also note that about 55% of patients who were randomized to get observation did end up getting some form of treatment in the future. So it's a little tough to know what that means exactly. This is just looking at, on the top graph, the sort of prostate cancer specific survival between the 3 arms. And this is sort of a similar graph to the one I showed previously, where they're looking at the number of patients who are still alive over time. And you can see that it's close to 100% of patients survived through the end of the 10-year follow-up. So no real difference there, regardless of which treatment arm they were on. In regard to patients who developed metastatic disease or developed progression, they did see that patients who went on to just observation alone, that they had increased rates of developing metastatic prostate cancer. So when you look at these 3 trials, I think, a couple takeaways is that there's pretty clear evidence across all of them that treatment can improve the chances that you won't develop metastatic prostate won't develop metastatic cancer, which is clearly important since metastatic cancer causes a lot of morbidity and other complications. What's a little less clear is that every patient with localized prostate cancer needs to get treated. And in fact, most of the data supports not treating patients unless they have intermediate risk or higher prostate cancer, since there's really not a clear benefit in terms of survival in patients that have lower risk cancer. And these observations really, fueled a lot of the conversations about why we need new strategies to treat men, or manage men rather, who have lower risk cancers. The idea is that, there's 250,000 guys that are diagnosed with prostate cancer in the US every year, but only a small fraction of them are really going to be destined to develop more complicated cancers that could potentially threaten their survival. And so how do you sort of meet in the middle and not overtreat patients that aren't going to have complications from their cancers, but at the same time, not ignoring this big health problem that clearly prostate cancer can result in. And so that's where active surveillance steps in. And so ultimately, the goal of active surveillance is to not sacrifice cure rates, but also to help to avoid some of the overtreatment issues that go along with managing these lower risk prostate cancers. Active surveillance can differ a little bit depending on the institution you're at. I would say that in general, most centers are only using in patients with low to low intermediate risk cancers. So that would mean typically no more than like a Gleason 3+4 prostate cancer. Usually it involves periodic PSA monitoring. Oftentimes they'll do it every 3 to 6 months. And then they get repeat biopsies while they're on active surveillance typically. And the interval that they do the biopsies can vary quite a bit depending on a number of factors, including, how many biopsies the patient's had in the past, how high risk their cancer was to begin with. Most centers, if they're going to recommend some form of local therapy, be it surgery or radiation, they require what we call pathologic reclassification. This usually means that you see the Gleason score go up, or you see that there's a higher volume of cancer. You see like more cores positive. Overall, and this number is probably a little dated actually, but last time I looked, which was I think a couple years ago, that about 40% of men in the US were managed with active surveillance, and this number keeps going up and up. You go back 10 years ago, and it's pretty rare that you'd find a patient who was on active surveillance, even with these lower risk cancers. But at this point, active surveillance really is a well-recognized strategy for managing these men with low-risk cancer. And a number of different professional societies, including ASCO, AUA, ASTRO, and SUO, all recommend active surveillance as the best option for guys with very low-risk prostate cancer and the preferred option for those with low-risk prostate cancer. And then I think, you know, depending on the institution, they're also recommending active surveillance for guys with favorable intermediate risk disease. And again, that definition can vary a little depending on where you go, but most often that means that you only see Gleason 3+4 cancer, and typically they'll also have some cutoffs regarding how high volume the cancer is in general. When you look at some of the data across some of the larger cohorts, you know, it's pretty clear that active surveillance is a safe and effective way to mitigate over-treatment of these lower risk prostate cancers. This is just some data from 5 of the larger cohorts that have been published, and you can see that the number of patients in each of these is listed as the top row there. We're talking about thousands of patients who've been followed for, you know, decades or more in many cases. But what they've showed essentially is that the cancer-specific survival, the likelihood somebody dies of prostate cancer, is exceedingly low. You're talking about probably less than 1% in most of these studies. Overall, between 25 to 50% of patients on active surveillance end up getting some form of local therapy, and probably around 3/4, 50% of men end up getting local treatment because they found some change in the pathology from their most recent biopsy. But you know, this data has really, I think, provided some assurances that, you know, active surveillance is in fact safe, and it is an effective way to avoid treating a lot of low risk cancers that were never destined to really threaten anybody's longevity. All right. So moving on to medical therapies for active surveillance. So, you know, when we first started thinking about, you know, how we can repurpose some of these drugs that we use for men with advanced cancers for guys on active surveillance, in my mind, probably the 2 main factors that we had to weigh was that, one, the drugs are well tolerated, and also that they're effective. I think well tolerated is an important part of this because, you know, one of the big goals of active surveillance is to avoid over treatment. And so, you know, one of the sort of questions I always get when I talk about this is, you know, well, if you're using these drugs that have, you know, side effects, does that really constitute active surveillance? You're treating these men and you're causing problems associated with, you know, these hormonal agents. So it kind of goes counter to the whole philosophy. And so I think that's an important thing to recognize. And, you know, if we are going to develop a medical therapy for active surveillance, it needs to be something that guys are going to tolerate reasonably well. And then the other aspect to it is it has to be effective. And this can be a little tricky, especially when you think about how we go about drug development. Traditionally, when as a medical oncologist, we try to design a drug or a clinical study that's going to lead to that drug getting cleared by the FDA for use in a certain setting, we usually have to hit a pretty high bar. We have to show that that drug is going to result in men living longer, not dying from their cancer. And that's clearly very, very important, especially for guys who have really late stage, incurable cancers. But in the active surveillance population, most men don't die from their cancer. It's less than 1%. So it's a little bit tough to prove that a medical therapy is going to improve survival in that context. One idea would be to look at pathology and whether or not the drug can change that to be more favorable. So for instance, if we were to do a biopsy immediately after medical therapy, do we see any cancer left over? If you don't, that may be an early indicator that the drug is in fact effective and maybe at least requires more development. Another thing that people have looked at is whether or not men who get the drug have lower rates of actually getting surgery and radiation. And that seems really clinically relevant, but it can be a little bit confounded since not everybody on active surveillance who opts for radiation or surgery has had sort of a change in their pathology that would have prompted their treating physician to recommend that necessarily. You know, there's a lot of reasons that a guy would want to get radiation or surgery. You know, living with cancer is hard, and I can understand, you know, potentially getting to the point where you just want to get it out of the way and, you know, have a surgery or something to put it out of your mind. And so it gets a little bit sticky to see that it's really the drug that's affecting the change positively. And so it's a challenging space to develop drugs. And I think that's one of the things that, is going to be something that I think, conversation with the FDA need to happen in order to allow us to get to the point where we can hopefully think of a strategy to move these drugs, forward in terms of developing them for men on active surveillance. There have been a number of studies, all of them relatively small, that have looked at some medical treatments for men on active surveillance. The biggest one was the REDEEM trial, and this was a study that enrolled over 300 patients, and they essentially looked at dutasteride versus a placebo, where men received the therapy every single day for 3 years. Dutasteride is not really a drug that we use to treat prostate cancers. Sometimes people add it on, but it's not by itself an effective prostate cancer therapy per se. It's traditionally used to treat BPH, benign prostatic hypertrophy. This study looked at pretty low-risk patients. They were Gleason 5 to 6 prostate cancers. And the primary endpoint here was what they called time to prostate cancer progression. And this was a composite where they looked at progression as being either a change in the pathology, so a guy gets a biopsy and their cancer goes from Gleason 6 to 7, for instance, or a patient opts to get treatment for their prostate cancer. And what they showed here was that essentially that progression at 3 years was lower in patients who got dutasteride. So 38% of men at the 3-year landmark ended up progressing versus 48% who got placebo at the 3-year mark progressed. And so this was a positive study based on how they designed it. Again, this is a composite endpoint here. So many of these patients came off study because they ended up opting for surgery or radiation, whereas maybe nothing changed with their pathology. And they actually see a significant difference in progress based on who the pathologic endpoint between the two groups. So with trial group, 29% of patients showed evidence of pathologic progression. They had some change on a biopsy versus 33% with placebo. So not really different there. And so, it's unclear whether or not the drug really had a big effect in terms of fighting back the cancer and preventing the low-risk prostate cancers from progressing. They did see that at the last biopsy per men on study that there was, however, a higher rate of men that had a negative biopsy, meaning that when they biopsied, they couldn't find any cancer at all. That was 36 versus 23% in men with dutasteride versus placebo. In men who actually made it to the 18-month landmark, they didn't really see a huge difference there. And so it's a little bit unclear exactly if it does have a high rate of causing the cancer to disappear on biopsy. And I think ultimately this was sort of not the primary goal that this study was designed to look at. So I think it's something that probably needs more follow-up. Another study was smaller, 98 men, but it looked at sort of a more traditional regimen that we would use to treat a guy with more advanced prostate cancer. In this case, they were looking at Leuprolide or Lupron, the injectable form of androgen deprivation therapy, plus an old testosterone blocker called Apalutamide. And in this case, they gave 3 months of the Lupron therapy, which was one sort of depot injection. And what they were looking for was whether or not patients had evidence of cancer on their biopsy at the 12-month landmark. This study also looked at low-risk prostate cancer, so men with Gleason 6 prostate cancer. What they showed was that 45% of men who went on study had a negative biopsy at the 12-month landmark. And this bar graph on the left here is basically looking at the results from this study versus the REDEEM study. So the bar on the far right there, you can see that the green is highlighting patients who had no cancer detected at 12 months, 45%, versus with the REDEEM study where they didn't see a big difference there in men that had their final biopsy on study, I think around 18 months or so, 42 versus 39%. The other bars there are looking at sort of the breakdown of when they did biopsy at the end of study, who had Gleason 5 to 6 cancer, which is the blue bar, versus those that had a sort of higher risk cancer, Gleason 7 to 8, which would be the orange bars there. So, those are pretty much the only 2 studies that have been published that had a decent number of patients prior to the one that we just recently presented at the SUO meeting last year. And I think there's a couple issues with them. For one, dutasteride, the data was, showed that there was a positive study that there's decreased rates of progression with the dutasteride group, but it's ultimately not a very good prostate cancer drug. It doesn't do a good job at killing prostate cancer cells, and ultimately, I'm not sure I see a real viable pathway forward for that. The other issue too is patients had to be on it chronically, basically every day for 3 years. The other study looking at the Lupron injections, they gave a 3-month injection of Lupron, but Lupron, the way it works is it essentially tells the testicles not to make testosterone, and it's not really like a light switch. You give the drug, and it's supposedly in your system for 3 months, but most guys are going to have a testosterone that remains low for many months beyond that. And so, it gets back to the idea of developing a therapy that's well tolerated. And, I just worry that with a drug like Lupron going on for well beyond 3 months' time, that's going to have some major quality of life issues for most patients. And so we wanted to basically refocus our attention on looking at a newer drug, a drug called apalutamide in men with active surveillance. Apalutamide is a really potent hormonal therapy. It blocks testosterone. It does it much more effectively than drugs like apalutamide, than bicalutamide do. It's currently approved for treating men with more advanced prostate cancers, and it's typically used in combination with Lupron. The two sort of indications for it are, one, guys who are just presenting with metastatic prostate cancer, and then it's also used to treat men who have gone through surgery or radiation and had a rising PSA, who subsequently went on to Lupron, and then following that, the PSA started rising. So this is a group that had started to develop resistance to Lupron alone, and in that setting, apalutamide has been shown to be effective at preventing the cancer from progressing further. And so it's something that we know is effective. It's a very potent agent. And I think importantly for me, I was interested in this drug specifically because we chose to study it as a monotherapy, not in combination with Lupron, because in a couple of small studies where they did that, they show that when you give just apalutamide alone, it blocks testosterone when you're receiving it, but in the background, testosterone levels actually go really high. And that's just your normal physiology. When you use a drug that blocks testosterone, all the normal cells in your body that use testosterone start signaling that they want it. And so your body's natural reflex is to start generating more of it. And so the idea was that you could take apalutamide by itself, testosterone levels will be high, and as soon as you stop it, the side effects would go away that are related to testosterone level being blocked. And this would be sort of a way that we could give discrete periods of treatment without necessarily having prolonged impacts on quality of life. And so what we hypothesized was that apalutamide would lead to negative repeat biopsies in men on active surveillance. We were looking to see whether or not getting a course of apalutamide would result in there not being any cancer that we could detect following treatment with it. And we also hypothesized that it should be well tolerated and hopefully over the long run lead to decreased attrition from active surveillance, that more men would stay on active surveillance if we can hopefully positively affect change in the prostate itself. This is the schematic for the study that we conducted. It's a little busy, but it's a relatively straightforward design. Essentially, we allowed men who had no more than favorable intermediate risk cancer. So again, just at most they could have Gleason 3+4 cancers. The PSA had to be less than 15. And then we gave them 90 days of this apalutamide drug, or ARN 509 was the original name of it before it actually got approved. And then after that, patients underwent prostate biopsies with sort of your standard template of 12 cores. And then we also did sort of targeted biopsies at places we knew cancer was present. And our primary objective was to look at how many men had no cancer that we could find after that 90-day period. We ended up consenting 24 guys. One patient wasn't eligible for one reason or another, and 23 ultimately enrolled and got 90 days of the apalutamide drug. There was one guy who, right around the 90-day mark, indicated that he was really too anxious to come into clinic to get the biopsy because this was right around the time that COVID-19 was sort of going crazy, and he just didn't feel like comfortable coming in for an elective biopsy, and we understood that, of course. And so 22 patients actually ended up getting their biopsy after this 90-day landmark. Additional 20 patients got biopsied at a year, and then at the 2-year mark, we had 4 patients with biopsy results. I'll just point out in this table to the right, which sort of lists the demographics for men on the study. I think one of the main things to look at is that we actually had a fair number of guys that had favorable intermediate risk cancer, so about a third of the patients enrolled. And this is in contrast to the prior 2 studies where everybody had low risk or even very low risk cancer. And so it was a higher risk group overall. And this is the primary outcome from the study. This is a table on the left just lists the pathologic findings from the back. We did it 90 days, 1 year, and 2 years. Which is 90 days and years. You can see that overall, the number of men who had a negative biopsy immediately following, which is 15% patients. So this is considerably higher than what we had seen in prior studies. And I think importantly, at the 1 year landmark, we still saw a third of patients didn't have any cancer that we could find. If you specifically look at those 13 patients who had no cancer at 90 days, about 55% of them, 6 of those patients, had no cancer that we could find at the 1 year landmark. And so it looks like essentially you've got 60% of patients with no cancer at 90 days, and of those 60% of patients, 55% don't have cancer at a year. And so the effects are pretty long lasting given that we're only using a 3-month regimen of therapy here. This plot is basically just showing the change in PSA on treatment. PSA, again, is a protein that's generated in response to testosterone and other androgens. And these bars are all going in the negative, which means the PSA dropped for everybody on study. Everybody had a PSA drop at least 50% compared to their baseline, and about 2/3 had a PSA drop over 90%, which is pretty dramatic for just a 3-month treatment course. This figure is looking at the average PSA over time, which is the orange bar. You can see that it drops during 90 days, and once patients come off study, we did see the PSA go up again and kind of plateau off. Most patients had their PSA plateau either near or slightly below where it was prior to going on study. But the blue bar, which I think is important, is the average testosterone levels on treatment, and you can see that actually goes up. So again, just like we had seen with other studies, when men go on apalutamide alone, the testosterone levels are high. And that's important, again, because when patients stop treatment, testosterone levels aren't suppressed for months on end, and a lot of those side effects that are consequent of low testosterone essentially go away with over a course of a month or so. This is just summarizing some of the sort of adverse events or side effects that we saw in the study. And essentially, we didn't see any really high-grade side effects for most men. Grade 3 means that it's sort of a little more than moderate side effect. One patient had a grade 3 blood pressure elevation, and another had a grade 3 rash. Rash is one of the known side effects of apalutamide. Both these guys were notably able to stay on study, and we do have additional quality of life data that we've generated through having our patients fill out surveys, which we still need to analyze. But anecdotally, from my experience taking care of most of these patients, the guys generally told me that they felt pretty well on therapy and that they would likely do it again if they were given the option. And finally, I just want to point out that there is a larger randomized study that is going on currently called the Enact Study. It's essentially looking at enzalutamide, which is a drug that's very, very similar to apalutamide in men on active surveillance versus just active surveillance alone, no drugs. This study is a randomized trial, so coin flip, patients either get the enzalutamide or not. And a little bit different than our study, they're actually giving men a full year of enzalutamide. And then they're targeting a similar patient population, lower intermediate risk cancers. And the primary endpoint is similar to the REDEEM study. They're looking at prostate cancer progression, which is this composite of either changes on biopsy or patient radiation. Overall, they're planning to enroll 222 patients and 220 patients and enroll 22 patients. They're planning to, I believe this study is still enrolling, so we potentially sort of know how effective this is. So just to summarize, active surveillance is clearly an effective and safe strategy to mitigate overtreatment for guys with low or low intermediate risk prostate cancer. Overall, about 25 to 50% of guys who go on active surveillance still end up getting surgery or radiation therapy. And developing medical therapies, in my mind, is a promising way that we can hopefully allow more of these patients to stay on active surveillance and hopefully avoid undergoing radiation or surgery, which is associated with a lot of complications. And it's certainly something that's necessary in many cases. But for these lower risk cancers, if we can affect positive change, I think that it would be something that's worth pursuing more. And so additional studies are going to be needed to follow up over the long run. And I think it's going to require, again, conversations with the FDA to really pin down exactly how we would design a study that would satisfy them in terms of allowing a drug to get approved in this space. But so far, I think we've seen some promising results with some of these more potent agents. And I look forward to following up on this trial, hopefully with additional studies. And of course, we'll also see what the results from the Enact study show in the coming years. So that's all I got. If anybody has any questions, I'm happy to answer them for you, or at least try to.
Okay. Oh, well, thank you, Dr. Schweitzer. Appreciate your perspective on active surveillance, and give you a little bit of an update. It's probably 50 to 60% of candidates for active surveillance, at least in the United States, who go that way now. Contrast that with 10 years ago when I started, when it was like 6%. So just so you're up to date.
Yeah,
But
no, I was putting this together, and I didn't have time to find that updated reference. I know that it's been going up, though. It makes a lot of sense for guys who don't have higher risk cancer. So
yeah, there's been a boost, especially in the last 5 years. But as a strategy, active surveillance has been evolving, and up to now, really no drugs have been in the equation. And I just wonder what your vision would be if the drug proves to be safe and effective. Is this for people who are very anxious? Who do you think would be the potential beneficiaries of this medicine, or
yeah,
any medicine for that matter?
yeah. So I think that primarily the benefit would be for guys who have probably not very low risk cancers, since most of those guys will probably be okay with just surveillance alone. To your point about very anxious patients, I think it's tough. One of the sort of critiques you get is that, okay, we're looking at things like therapeutic progression, guys that end up going on to get surgery or radiation who get a drug or don't get a drug. And it just makes intuitive sense that if you give a drug that's going to knock the PSA down and maybe hold the prostate cancer in check, at least for a little bit of time, that you'd have more men who avoid local therapies. And whether or not that is really affecting sort of the natural history of that cancer, or it's just sort of a psychological effect because you're managing anxiety around PSA levels, I think that's something that's tough to sort of suss out. These are some of the critiques that I get in trying to develop these studies, and they're hard questions because, again, at the end of the day, most prostate cancer trials, or any cancer therapy for that matter, they really have traditionally only approved treatments based on, extending survival. And for active surveillance patients, we know that guys on active surveillance are almost certainly not going to die of their cancer. And it's more about the quality of life aspects and avoiding the morbidity associated with radiation and surgery. And so it's tricky to sort of sort those out. But, I guess to answer your question, I think probably the primary role for medical therapy being guys who are maybe on that cusp, that borderline of being appropriate for active surveillance. Maybe there's something about their case that worries you that's going to progress in the absence of some kind of medical therapy to get it under better control.
You mentioned some of the critiques that you've received, and I want, I'm thinking about this. It almost sounds like, this could be, in effect, it might have a medical benefit. It might have also a psychological benefit, almost like a placebo. And if it's just a placebo, how do you justify it?
It's tough. You're right. And I think, again, there's a lot. I know, because I treat a lot of prostate cancers. There's a lot of anxiety around things like PSA, but historically that has not been something that we use as a trigger to say that somebody needs to get an operation or radiation therapy. But we can manage your PSA with things like dutasteride, and we can manage it with things like apalutamide. But ultimately, I don't think that if I knock your PSA down and you use that as your justification for not getting surgery or radiation, that's really a compelling case for using the drug in that context. You really want to show that the drug is doing something to really change the natural history, the course that cancer would have taken had you not used the drug. And so to me, that's why we built our study around these biopsy related endpoints, looking at seeing no cancer after a certain period of time, because that's a little bit more directly reflective of what the drug is doing to the cancer itself. Whether or not the FDA would use that as an endpoint that would allow them to approve a drug in that space, I think that's a bigger question, something that we probably have to take up with the FDA directly. So
Well, and by the way, I encourage everybody to submit questions, and pretty soon I think Hugh will be weighing in as well. But you bring up an interesting point too, which is, how do they justify, can they justify surgery or radiation just based on a man's uh, anxiety levels?
I think they do that. I mean, there's choices that are personal, and I wouldn't argue with the patient if he were to tell me that, hey, I've got a Gleason 6 cancer, but I living with this cancer every day is a burden and it's stressful, and I'd rather just treat it. And that makes sense to me on some level. I think it's a tough thing to sort out. And we talked a little bit about some of the localized therapy trials, and it seems pretty clear that guys with low risk cancer are probably not going to die from prostate cancer, but they may still develop metastatic cancers that can cause a lot of issues for them, like pain and other morbidity. And so if getting a surgery or radiation with the idea being that, maybe I won't die of prostate cancer, but I also don't want to have to live with metastatic prostate cancer, and this is a way to avoid that, that makes sense too.
Yeah. Let me ask you from a cost point of view, how expensive is this medication?
Oh, it's very expensive. And that's a big issue too, especially when you think about, how you'd incorporate that into your treatment paradigms. Apalutamide, I don't know the exact cost, but I want to say it's in the ballpark of like $10,000 a month,
Ooh,
maybe a little more.
ooh,
Yeah.
attention.
Um, yeah, Hugh, are you picking up anything here?
Yeah, we've got one that came in from Mark, and he says, is it only a receptor blocker or testosterone production blocker? Does it work with DHT, or does it reduce free testosterone in DHT?
Apalutamide is only a receptor blocker. It does nothing to decrease production of any androgen, whether it's testosterone or DHT or any of the other ones. And so that was one of the reasons we chose it, because all the drugs that result in testosterone production going down, even when you stop those drugs, there's usually a lag of, a bit of time before they come up again. Now, some of the newer drugs like Relugolix or Degarelix, they probably have a quicker time to testosterone recovering compared to older drugs like Leuprolide. But, we developed this study before Relugolix was around, and we felt that it was probably a good option in terms of, the side effect profile, which is part of the reason we chose it too.
Now, I noticed these studies, it looks like pretty much they're always with biopsies. Have anybody been proposing these kinds of studies and just using MRIs or ultrasounds to kind of monitor the progress?
Yeah, not that I know of. We did have a handful of guys that got MRIs as part of this study we ran. I can say that our center, the urologists aren't doing, they're not doing as many MRIs on active surveillance patients as I think other places are. And so it was really just too few to make any heads or tails of it. But most of these trials are still requiring biopsies, but I think they also do include sort of allowances for getting MRIs as well. Granted, you also still need to get a biopsy as part of that.
Yeah.
Yeah, I noticed on your list of medications that you had Provenge, and we're going to have a speaker later in the summer talking about a Provenge study for men on active surveillance. And
Yeah, I'm sorry I didn't mention that. And somebody in the chat brought up that I forgot the Provenge active surveillance study, which is my fault. But yeah, there is a study looking at using Provenge in active surveillance patients. I have to say, based on the experience using that in a castrate resistant setting, I'm a little bit skeptical it's going to have a positive effect there. But I'd be more than delighted to see a trial that came back positive in that setting too. So.
yeah, we're
So
going to have Dr. Shore on that. Yeah, go ahead, Rick.
can I just say something, Dr. Schweitzer? When Larry Fong was developing Provenge, 2008, 2009, they actually did a trial on men who got Provenge prior to a radical prostatectomy. And what they found when they sliced and diced the prostate. And there were actually slides on this, and he showed us the slides recently when he did a presentation for us. It was that the dendritic cells circled the tumor. So it wasn't so much that they prevented the prostate cancer, but they kind of encircled it and stopped it escaping and going anywhere. And that study sort of got forgotten. In fact, many years ago, one time I was sitting in an audience with Larry, and with the people were talking about it, and I reminded him that he had that study, and he said, "Oh yeah," and he presented that to us about a month or 2 months ago. So it's really, really intriguing. Really intriguing.
Yeah, no, I agree, and I do remember looking at that a while ago. Yeah, maybe I'm just again colored a little bit by my experience using Provenge in the clinic, where you don't, it really just hasn't panned out to be this sort of blockbuster that everyone hoped for when it was initially approved. But yeah, I mean, it's to your point about sort of showing increased inflammatory cells in the prostate, that could correlate with better outcomes and may decrease rates of progression. I mean, it's true across many different cancer types that the tumors that have more immune cells that are penetrating it, that look more inflamed, that the outcomes are better. And so maybe it'll hold true in this setting too.
Yeah, I think the biggest issue with Provenge is how do you show that it's effective? And unfortunately, the studies that got it approved were with men at such late stage cancer that it didn't appear to have much of an effect. But if you follow Larry's advice, which is give it the longest landing strip that you possibly can, maybe it does have more effect, and we really haven't studied that well enough in detail.
I agree. And I've told the folks at Dendron, I'd love to see them do additional studies to look into those things, like moving it into men with newly diagnosed metastatic cancer, maybe combining it with other more potent immunotherapies like checkpoint inhibitors. But I think that company's just barely holding on in terms of their financial livelihoods. I don't know that they have the $1 billion to invest in something like that, but it's a shame. I think there is some interesting biology there. It's just not being used. I don't think it's being used correctly. I agree with you.
Yeah, Michael, something very basic. I believe you're the first medical oncologist that has spoken to this group. And I remember a couple of years ago asking a medical oncologist friend at City of Hope, should I see him? And he said, he was the last guy I wanted to see. And I wonder if you can explain a little bit about the relationship between medical oncologists in general and men with low and intermediate risk prostate cancer.
Well, we don't have much of a relationship, frankly, because usually men with low intermediate risk cancer get managed by urologists and radiation doctors. I unfortunately don't get to cure my patients usually because, I, for the most part, manage guys who have really advanced metastatic cancers. Sometimes I, step in and help with the hormonal therapies that go along with radiation, but, it's something where we don't have traditionally a big role in terms of active surveillance. But I was interested in looking at it mainly because, again, we've had all this sort of boon in drugs that are really effective. And the idea was, could we use them to hopefully allow us to help these guys stay on active surveillance longer? But, traditionally, I'm not somebody that typically sees patients who are on active surveillance. So,
are you still enrolling people in this study?
this study's done. We're cleaning up some of the data, trying to finish up some of the correlates, some of the sort of scientific studies as part of it, and then we'll probably publish it. And then I'm going to start talking to companies who own these drugs to see if we can maybe do a follow-up.
And you used the word cure a moment ago. So I mean, are you viewing this this drug as a potential curative, or is it more of a maintenance drug?
My sense is, based on this small study, of course, is that it's probably more of a maintenance thing, that it may be a way where guys could periodically get sort of discrete courses of apalutamide to suppress the cancer as it starts to show signs of growth, for instance. And maybe that'll allow them to avoid undergoing the knife or getting radiation therapy. That's sort of how I would envision it being used in a strategy. And again, for me, cure is a tough word. I mean, I usually think of it, if a guy lives to their whatever their normal life expectancy is and doesn't die of cancer, I think that's probably just as good. And if they can do that and avoid having to undergo a prostatectomy, even better.
Doctor,
Gotcha.
we got a question in from Philip. It says, if a biopsy, even with a drug such as I'll butcher the name.
Apalutamide.
Yes. How do we know it's the drug that led to the negative biopsy, or did the biopsy just miss detecting the PCA? Given the cost, why would anyone on low risk or even intermediate risk use it?
Yeah, no, it's a great question. So the first one, how do you figure out if the negative biopsy is from the drug versus just, missing the tumor with the needle? The real way to do it is to do a big randomized study where you're going to show that there's a statistically higher rate of negative biopsies with the drug compared to guys that didn't. We know from other studies that probably somewhere around 20 to 30% of patients on active surveillance, if they get a biopsy, they may have a negative one just based on the fact that they missed the tumor. And so you're right, we need to do a bigger study with more men and randomize them between either getting the drug or not to really prove that. The second point about the cost of the drug and why would you do it, that's a tough one. And I think that's probably a question that's relevant to almost any cancer drug we have. Currently, the way it works in terms of, payers, insurers, and how they decide on a drug, it's not so much about the cost in terms of whether a drug's approved or indicated for a condition. It's more about whether it's been shown to have some real clinical benefit. And, I think parsing out care based on the cost of things is something that we historically haven't done in the United States. And it's probably a conversation that is beyond the scope of something like this. But, other countries like Britain, they do take into, account some of the costs associated with cancer care and whether or not there's a good, return in investment and whether the benefits you see with a drug really justify the cost of it. But, it's part of the reason we spend so much in this country in healthcare is because we don't really take that into our calculus when figuring out, whether or not we're going to use a drug for a certain condition. For an individual, I would say that it would be a pretty tough sell to say, give me 30 grand so I can knock your cancer down for a year. I personally probably wouldn't pay that amount of money. If your insurance company would, maybe, but it's a sticky question for sure.
You had that long list of medications. Why did you choose this one to look at? And how does the dose that you used on these men on active surveillance compare with the ordinary dose on men with more advanced disease?
Yeah, so, there's a lot of different drugs we could have chosen. I wanted to use one of the newer drugs that's very potent because these are the drugs that really have shown so much promise in treating really advanced cancers that are really tough to treat. The other aspect too was choosing a testosterone blocker was again related to the fact that when you stop it, testosterone levels are still high, and as soon as it's out of your system, side effects start to go away. And so those were sort of the considerations. Why did we choose this drug over other ones? Mainly because the people that manufactured it were willing to give it to us to run this study. There's sort of pragmatic considerations trying to do these trials is you come up with an idea and then you see if you can make it happen. Ultimately, running a study like this is very expensive because the drug's very expensive, and so we had to convince a company to give it to us to even run the trial. And Janssen, who makes apalutamide, was willing to do it.
So you say this is a drug that is usually used on more high risk cancer patients. What is the success rate at that level?
They measure success a little differently in that setting. And so, when they use it in guys with advanced cancers, these are all incurable cancers, and most men are going to die of their prostate cancer on these trials. And so typically when they run those studies, they try to show that men live longer when they get this drug versus not getting it. And so, for instance, if you were to get apalutamide as part of your upfront therapy after presenting with metastatic prostate cancer, on average, guys live about a year, maybe a year and a half longer if they get it versus do not. And so, we're talking about not dying of your cancer in this group, but for a patient who in 2021 presents with metastatic prostate cancer, the average survival is probably 5.5, 6.5 years on that ballpark. So, adding a year to that can be meaningful.
You know, the side effects you listed sounded very minor. Um, you know, level 3 or something on rash and so on. We got a note from somebody who's not at the meeting asking about side effects. I mean, I read a list of potential side effects with this medicine, and there were a lot.
Yeah.
And but this fellow is asking specifically about growing breasts. Is that, I don't know why that's a fetish for him, but is that an
Yeah.
issue?
It's not a fetish. It's something that can certainly happen. So, with this drug, it's usually given in combo with Lupron or other ADT type injections. Sort of common side effects of any drug that blocks or lower testosterone are things like fatigue, hot flashes, decreased libido. It can cause you to lose muscle tone and bone density if you're on them for long enough. So, those are real side effects. The breast growing issue is something that they do see with these testosterone blockers. We didn't really see that on this study, and I think it's probably because we only used it for 90 days. If I remember, I think there might have been one, maybe two men who had some nipple tenderness near the end of their treatment, but that tended to go away after they came off study. And so I think it just relates to sort of the short duration of therapy. But yeah, side effects are real. And I would say that most men, they tell me after they finish the study, they were glad they did it and overall it was tolerable. But I'll also say that, near the end of the treatment course, most guys were happy to be done with it. So
So what is your next step with this? You said you were going to approach the drug companies. Are you going to approach this particular one, or you're aiming to fan out and look at
no,
some of
I'm,
the
I'm
other?
not I'm not wedded to Janssen. I would say, again, there's three drugs that would make sense that are essentially identical in a lot of ways. This enzalutamide drug, which is currently in a study, so they probably won't do another one. But then there's apalutamide, which we studied, and a newer one called darolutamide. So I'll probably talk to the companies that make apalutamide and darolutamide about maybe doing a follow up and see if we can get any traction there. It's tough because you think you have a great idea, and I think this is a good idea, but trying to convince a company to invest in it can be challenging, and that's sort of something that the battle that I
It
have to fight.
may be easier, Mike, now that Chuck Drake is over there. You may have a more receptive ear.
There you go. Yeah, and I know Chuck. I did my fellowship training at Hopkins when he was still over there. So
Oh, wow. Wow, wow. And I don't know what sort of relationship you have with Bayer. We have some fairly good relationship on the medical side. So any way we could help you, and Ancan loves darolutamide. We've got one of our board members actually who's been on monotherapy darolutamide under William O for 18 months and is doing great with
yeah,
monotherapy.
I only have a handful of guys I've used it for, but I've been impressed. I mean, I think there's a lot of sort of pharmacology behind it that really makes sense, and hopefully it does pan out that it's better quality of life associated with it. So I appreciate the endorsement. I'm trying to get this first paper off, and then we'll hopefully start trying to circle around and see if we can gain some more traction with the next one.
Well, don't hesitate to come back to me through Howard or to us, and we'll do whatever we can to help you.
That's great. Appreciate it.
Do you find enough people for your studies, patients?
This study was a little hard in terms of enrollment. It took a long time, and I think we had maybe the first year of the trial, we just didn't have a good sort of pipeline for getting patients from the urology clinic who manages these guys into the medical oncology clinic. But near the end of the study, we picked up steam and we're really moving along quickly. We would have liked to enroll a few more, but ultimately Janssen started to feel like they were tired of supporting this trial and wanted to move on to the next one. So they told us to pull the plug, which we did. But yeah, I think now that we kind of worked out those kinks, the next one should hopefully go up a little bit smoother.
Wasn't there an earlier study of the same medicine in the same way, I think from France?
I don't recall there being another apalutamide active surveillance study. No. If there's another one going on now, it's possible, but this was the first apalutamide active surveillance study to get published. Or to
So
get
Hugh,
reported on.
sorry about that. Hugh, how's it looking on your end?
We're pretty caught up on anybody in the chat box, so we're about there.
Yeah, I do see one question about risk for developing hormone insensitive or castrate resistant cancer because of this, and I think somebody followed up saying that it's unlikely, and I would agree with that. 90 days of treatment, I don't think it's long enough to drive resistance to the treatment. So.
So Joe, what do you think?
Put me on the spot there for a second. Okay. Actually, I think we did pretty well. And I know I gained a lot out of it.
One thing I'll say is I thought your presentation, Doctor, was you gave a great background of prostate cancer and everything else that before you got into your specifics. It was a great presentation.
Yeah, thanks. I think it's important to have a little bit of the sort of historical context for why we're even doing active surveillance now. So,
your description of some of the treatments and everything else, it was really good.
Thanks.
So
that's something I think we're going to make sure that we refer, especially a lot of our new members as they come in, to make sure that they come take a look at that presentation.
right. So what do you think, Joe?
I think we need to just remind people about the survey coming up, and
Okay.
if we do get any additional questions for Dr. Schweizer, we know how to get in touch with them, so we'll be glad to pass them along. But I think it was a very comprehensive presentation. Thank you.
All right, my pleasure.
I'm going to post a couple things more. Okay, I just got to copy them. So, Dr. Schweitzer, do you have any questions for the men on active surveillance? We'll turn the tables on you.
Yeah, I mean, I guess, I'm interested to get folks' perspective on whether something like this is sort of would fill a need. Ultimately, active surveillance is about, the patient experience and trying to improve quality of life. And, I guess it's hard without the sort of experience of what it's like to actually be on a drug like this. But do you think there's a role for something like this in helping to, maybe mitigate overtreatment and allow patients to stay on active surveillance for a longer period of time?
Yeah, I think so.
Yeah, I'll jump in. I'm somebody who's been on active surveillance, not a great deal of time, and I've used this great support group to keep up on things. But I've often pitched here and said, just active surveillance of sitting around and watching for something to change. Shouldn't we be more active in addressing how to stop it at the very earliest stages? The answer is always, what are the side effects for anything? And given that that there's a chance that it won't progress on its own, but I'm one. Yeah, what can we do to stop it at its earliest stage? So I'm very interested to hear it.
Hugh, I think the active part, is emphasizing, monitoring and diagnosing. What you're saying is, can we be more active in addressing it?
Yes, at its earliest of stages. A number of people, really look at this also with diet, and I think there's some evidence that big changes in diet can have some effect. I don't know if you've looked at any of the studies compared to the success that you're having with just the diet changes.
Yeah, we haven't compared it directly. I mean, again, this study was pretty small, so ultimately it's going to be hard to compare even across trials like that. It's a challenging period, but it's going to be hard to sort of put it into sort of bigger context without having a larger follow-up, more patients, that kind of thing. But I'd be interested to see if diet can play a role too. Clearly, that's probably a heck of a lot easier than taking an expensive cancer therapy.
Well, 10,000 a month. You can buy a lot of broccoli with that.
You
But
can, yeah.
in fact, broccoli all around for everybody. But I know there's a group. I've been trying to reach out to them at the Fred Hutch that's been studying diet and exercise.
Mhm.
I don't remember the name of the researcher, but look them up. Maybe you can collaborate. Who knows?
Yeah, there you go.
Boy, we're
Uh,
getting some bad feedback here.
Yeah, the only thing I would like to just say is all these guys on this call, and you've got an eminent genitourinary medical oncologist looking for feedback. Speak up. Hugh's the only one that's got an opinion on this. No one
Well,
else.
you weren't listening to me. I gave an opinion, so don't yell at me.
We always listen to you, and we know you have an opinion. That's why you do what you do, Howard. We love you for it. But what
Well,
about all
don't.
the rest of the guys in here? No one else want to have any
Well,
wisdom?
let me be specific. Phil, are you still there, Phil? Phil,
Make sure that Joe hasn't turned them all off.
No, I haven't. Actually, Dr. Schweizer will tell you, in our walkthrough, I chose the opportunity to get some good advice from him, for my case. So,
Well, good going, Joe. Phil's
yep.
up there. Phil, what do you got? What's your thought on this from north of the border? Make your turn on. You're muted.
Phil is the one who actually recommended the
Oh
program.
yeah, here. No, I thought it was a terrific presentation. I really enjoyed the summary on active surveillance. It just probably one of the more thorough presentations I've seen. My problem again would be, gee, I guess if it's for somebody who's on intermediate risk, perhaps it might make sense. But I guess for somebody who's been on low risk for a long time, I don't know whether you could convince me to take the drug.
Yeah, I would tend to agree with you. I think that it's really about trying to refine sort of our criteria for who would be appropriate. The study as we designed it was pretty open in terms of, patients being able to get on across the entire spectrum. But, we had conversations amongst ourselves. We really were trying to look at those guys that were, either to Howard's point, really anxious and wanted to do something to treat their cancer, or probably for me, the more important group was guys that had sort of intermediate risk cancer or cancer that was kind of on the borderline of whether I'd recommend active surveillance in the first place. And there's a lot of guys like that. So
Yeah, for sure.
So we should thank Phil for suggesting this. He's monitoring everything, and he wrote me a note, and I made the pitch to Dr. Schweitzer. So it's like a double play combination. So come on, guys. Anything else out there?
So I guess we might end up getting the opportunity to invite him back again, huh?
there you go. Hey, and listen, if anybody wants to shoot me an email offline, feel free, Howard or Joe, to share my email with the group. I'm happy to sort of chat offline too about things.
Look, it looks like Nick Minervini has a question. Joe.
Yeah, thanks, Rick. At Rick's urging, I'll chime in here. So I'm intermediate risk, favorable intermediate risk, and I've been keeping close watch and track of patients that have selected focal therapies and kind of view continued management versus cure of the prostate cancer. I think that's a big decision point. Do you choose to try and continue to manage this with active surveillance, or a focal treatment that you hope has better preservation of normal function? A big problem with a lot of those that I see, and this currently fits in that category, is there's no coverage. So it's extremely expensive. I've looked into HIFU and Tulsa Pro as options, and I've got to rationalize that that's the best use of my limited funds and resources. So as your research continues, I think that's a real quandary, because if it's approved, but there's no coverage or these drugs are massively expensive, it's only going to be accessible by a very small percentage of people that would even want it, because it's just not affordable. So that's a
Yeah,
huge challenge.
it is important, and the way they go about doing sort of coverage for drugs versus a procedure is a little different. If we had a drug that was FDA approved for active surveillance patients specifically, then in general, that's something that would be covered by your insurance. Now, there's still considerable out-of-pocket expenses for a lot of guys. If you think about it, depending on your insurance, you may have a copay of $0 versus up to maybe even 20% of the cost of the drug. And 20% of, 10,000 a month is still a lot of money. That's like $2,000 a month still, right? So, the cost issues don't necessarily go away, but, my goal, if this was a strategy that, pans out, will be to try to get something that was FDA approved so that insurance companies would have to pay for it. But you're right, these cost issues are a huge problem, and it extends to pretty much everything I do as a medical oncologist, since many of my drugs are in the 10,000 plus a month ballpark. So, yeah.
So, following that up, Mike, an interesting thought, even though I totally understand why you lent towards apalutamide, but it would not be that expensive to run a study with, say, high dose bicalutamide, maybe 100 or 150, for exactly the same 90 days, and see if you got the same results.
Yeah,
the drug will be accessible because it's generic.
That's true. Yeah, we could. It gets to be challenging when you're doing these studies. Because potentially to do a study like that, we'd probably have to go to the NIH and try to get a grant to fund it. And it can be pretty challenging to get those types of grants because you're going up against people that are doing a lot of really cool basic science, which is traditionally where they steer their cancer funds. So the majority of clinical trials that are funded go through the pharmaceutical industry. So, if you think about, this study, Janssen has a vested interest in developing their drug. They'll pay for this because they can make 10 grand a month off of selling it down the line potentially. So it's a tough place to be in. I certainly, would agree with a cost-effective approach. It can be a bit of an uphill battle to actually find sort of the funding to pull that off, though. And you find that even with a relatively cheap drug, it gets pretty expensive to run a clinical trial. Just sort of paying for the infrastructure at the cancer center and having the coordinators and the data managers, it eats up sort of a traditional sort of R01 type budget that you might get for a more basic science experiment.
I think you got to get hold of Howard, and then you do a GoFundMe for all of the AS men out there.
There you go. All right.
Yeah, I could hold a tin cup. I'll put out a tin cup and it'll say, "Help this poor guy on active surveillance."
Anybody know how to play an instrument? We could get out there and start busking. So.
Yeah, I'd be happy to do it. Just let me know.
Howard would have played the violin for you, but he cut off his ponytail. So he can't play the violin now that his ponytail's gone.
I had no idea it was
Well, I wasn't making the money. I used to doing it because the streets in Chicago, nobody was out. And then, as usual, my timing was bad. I missed the Memorial Day thing, decided to stay home. But hey, let's bring up another question that Dave Crone mentioned. I don't know if Dave's still with us, but we can ask. He said, "I have avoided participating in studies because of the repeat transrectal biopsies. I would be much more receptive if transperineal procedures were available." So any thoughts on that?
It's interesting. The transperineal is typically, a little more invasive, and I think the risk is higher. So I understand that, the level of sedation's up there, so you probably don't perceive it as being an issue. But, typically we've done transrectal just because it's, typically what urologists do in their normal workflow. Personally,
Things are going to change.
Yeah, and I know personally, I'm not a urologist. I don't do the biopsy. So if they get me the tissue, great. I don't have any sort of objection to that necessarily, but I don't know if that's at this point considered standard of care in terms of following folks on active surveillance. If it changes, yeah, by all means, that's not something I would be opposed to.
Yeah, well, it's changed in Europe and Australia, and it's starting to make some moves at the American Urological Association. So come back in a year, we can talk about it.
There you go.
Okay.
So shall we call it a night?
I think we've done well. And Michael, thanks again very much. We do appreciate your participation. And you know, we've had a really nice attendance, good attendance to this, and a lot of folks stayed right to the very end. So that indicates that we got a good message across, and that's appreciated.
Well, let me throw a couple of other things out there too.
I'm to tell them I'm going to contact buddies down at Jeff, so you know. I'm going to contact buddies down at Jeff for me.
Yeah, I did post the doctor's email address, so feel free to flood him with questions that you were too embarrassed to ask tonight. I'm sure he has nothing better to do.
That's right.
But he'll be happy to help. And don't forget to fill out our survey, otherwise you're dead to us.
Howard, can I say a quick thing?
Yeah.
I got on the call late. I'm sorry that I missed it. The Memorial Day threw my whole thinking off. But anyway, I completed the survey, and you guys make such a concerted effort in this field that I'm kind of putting a plea out there to everybody that's still listening. Hopefully that they will, complete it so you can at least, I believe you need 100 surveys, at least 100 surveys to compile the data or whatever. I certainly hope you exceed that expectation. And I was on the webinar on Saturday, and I thought that was fabulous. I stayed for the hour and a half, and it was really great. And again, thank you guys for what you're doing. Dr. Schweitzer, from what I heard, I really liked what I heard. Very informative. I'm sorry I missed the beginning of it, but maybe I can go back and catch it later.
Well, we will have a video.
Okay.
And and we do try to put the fun into active surveillance.
Well, the webinar on Saturday was very informative too, and Dr. was Andule or
Andrea.
Yeah, terrific. It was great. It was good. That's all I got, gentlemen. Thank you so much. Sorry I got here late, but I'm glad I'm here.
Better late than never, right?
Yep. Thanks again for what you do, for sure.
Yeah, the recording will be posted in a couple of days.
Okay.
Okay.
And Dr. Schweitzer, feel free to leave us. You've given us plenty of time. Thank you.
Very much.
Thank you.
Thank
You
you
guys take
very
care.
much.
It's been fun. All right, we'll stay in touch.
Thanks,
Bye-bye.
I hope so. Thank you.
Thanks again. Sure appreciate it.
Thank you.
Thanks for everybody.
Okay.
Thank you, guys. Thank you very much for tonight.
Thanks, Mark.
Yes, sir. Have a good day.
So once
Thanks,
again,
you guys,
I will
for hosting this.
just ask the team to